Hi, good day. I'm Zeke. Today we will discuss about what is acute coronary syndrome and myocardial infarction, together with a friend named Rigo, the robot. Acute coronary syndrome and myocardial infarction. What is acute coronary syndrome and myocardial infarction? Acute coronary syndrome is an emergent situation characterized by an acute onset of myocardial ischemia that results in myocardial death, also known as myocardial infarction. For simple definition, acute coronary syndrome means there is a blockage in coronary arteries, which will result in death of a heart muscle or heart attack, also known as myocardial infarction. Pathogenesis. Our heart is a muscular organ that pumps blood containing the oxygen and nutrients our body needs. The main pumping chamber of the heart is the left ventricle. When your left ventricle contracts, it sends oxygen-rich blood to your body through a large artery called aorta. Connected to your aorta are small arteries called coronary arteries. Blood flows from your aorta to the coronary arteries to supply our heart with oxygen and nutrients, also known as coronary circulation. If you have acute coronary syndrome, blood flow from your coronary arteries is severely reduced or completely blocked. One possible cause of reduced blood flow is atherosclerosis. In this condition, a buildup of a fatty substance called plaque can narrow your coronary arteries. If this plaque ruptures, a blood clot can form and block the artery. A blood clot is the most common cause of coronary artery blockage. Other less common causes of reduced blood flow include coronary artery spasm or dissection. In a coronary artery spasm, it is commonly triggered by drugs, smoking, cold weather, extreme stress, or emotions, which cause temporary and sudden tightening of coronary artery. During a coronary artery dissection, the inside wall of coronary arteries separates, which can block blood flows. Regardless of the cause, a blockage in either coronary artery prevents the oxygen and nutrients in your blood from reaching the part supplied by the artery. As a result, heart muscles in that area starts to die. Death of part of your heart muscle is called a heart attack. It's also known as myocardial infarction or MI. A major complication of MI are arrhythmias or abnormal heart rhythms, with the highest risk of being immediately following an MI, since the damage or injury can disrupt how the cells conduct electrical signals. Kind of along the same lines, depending on how much contractile muscle tissue is affected, the patient's heart might not be able to pump blood enough to the body, resulting in cardiogenic shock. In the days following the infarction, the tissue around the infarcted area becomes inflamed and is invaded by neutrophils, which can lead to pericarditis, or inflammation of pericardium. In the next couple of weeks, macrophages invade the tissue and the healing process begins in the formation of granulation tissue, in which new connected tissues that is yellow and soft. At this phase, the tissue is most at risk of myocardial rupture. After 2 weeks and several months, cardiac tissue scarring process finishes, and the resulting tissues result in grayish-white in color. Since the scar tissue doesn't help pump blood, over time the remaining heart muscle can grow and change in shape to try to compensate for these lost cells and pump harder, which eventually continue to fail, which leads to heart failure.
Hi. Good day. I'm Rigo. I'm Ezekiel's friend. I'm the fruit of Ezekiel's imagination. Ha 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 ha. Sorry, that is how I laugh. So bear with me. Due to technical problems, his pre-recorded video is corrupted. I was tasked to report about what are risk factors, signs, and symptoms, diagnostic evaluation, medical treatment and prognosis of acute coronary syndrome and myocardial infarction. Factors that contribute to development of acute coronary syndrome are classified into two: the non-modifiable and modifiable factors. For non-modifiable factors, this include: Number 1. Age, risk increases with age. Number 2. Sex, particularly in male, women typically suffer from heart disease 10 years later than men due to the postmenopausal decrease in cardiac protective estrogen. Number 3. Race, non-white populations have increased risk. And number 4. Family history of illness. For modifiable factors, this include: Number 1. Drugs such as cocaine and smoking. Cocaine use and cigarette smoking can cause severe spasms of the arteries. This causes the heart to work harder. In many people, coronary artery spasm may occur without any other heart risk factors, such as smoking, diabetes, high blood pressure, and high cholesterol. Cigarette smoking damages the walls of your blood vessels, making them more prone to accumulate fatty deposits. Smoking might also lower your level of HDL, or good cholesterol. Number 2. High blood pressure. Arteries narrowed and damaged by high blood pressure have trouble supplying blood to your heart. When blood can't flow freely to your heart, you can have chest pain or angina, irregular heart rhythms such as arrhythmias or a heart attack. Number 3. High blood cholesterol. Cholesterol is a waxy substance found in your blood. Your body needs cholesterol to build healthy cells, but high levels of cholesterol can increase your risk of heart disease. With high cholesterol, you can develop fatty deposits in your blood vessels. Eventually, these deposits grow, making it difficult for enough blood to flow through your arteries. Sometimes, those deposits can break suddenly and form a clot that causes a heart attack or stroke. High cholesterol can be inherited, but it's often the result of unhealthy lifestyle choices, which make it preventable and treatable. A healthy diet, regular exercise, and sometimes medication can help reduce high cholesterol. Number 4. Diabetes. Excess blood sugar decreases the elasticity of blood vessels and causes them to narrow, impeding blood flow. This can lead to a reduced supply of blood and oxygen, increasing the risk of high blood pressure and damage to large and small blood vessels. High blood sugar contributes to higher levels of a dangerous cholesterol called very low-density lipoprotein, VLDL, and lower HDL cholesterol. High blood sugar also damages the lining of your arteries. Number 5. Physical inactivity and sedentary lifestyle could be a factor for increasing the cholesterol level of the body. Number 6. Poor diet. Eating saturated fat, found in animal products, and trans fats, found in some commercially baked cookies and crackers and microwave popcorn, can raise your cholesterol level. Foods that are high in cholesterol, such as red meat and full-fat dairy products, will also increase your cholesterol. And number 7. Being overweight or obese. Having a body mass index BMI of 30 or greater puts you at risk of high cholesterol. Acute coronary syndrome is commonly associated with: Number 1. Chest pain or angina. It is important to remember that chest pain that occurs while exerting and if the person rests and the pain goes away thus is usually called as stable angina. Unstable angina, on the other hand, occurs even at rests. The characteristics of chest pain include: severe, diffuse, steady substernal pain, may be described as crushing, squeezing, or dull. Not relieved by rest or sublingual vasodilator therapy, but requires opioids. May radiate to the arms, usually the left, shoulders, neck, back, or jaw. The duration continues for more than 15 minutes. And it may produce anxiety and fear, resulting in an increase in heart rate, BP, and respiratory rate. Nevertheless, other cause of chest pain such as aortic dissection, pulmonary embolism, esophageal perforation, and pericarditis must be considered in the differential diagnosis. Number 2. Diaphoresis, cool clammy skin and facial pallor. Number 3. Hypertension or hypotension. Number 4. Bradycardia or tachycardia. Number 5. Premature ventricular or atrial beats. Number 6. Palpitations, severe anxiety, and dyspnea. Number 7. Disorientation, confusion, and restlessness. Number 8. Fainting and marked weakness. Number 9. Nausea, vomiting and hiccups. And number 10. Atypical symptoms such as epigastric or abdominal distress, dull aching or tingling sensations, shortness of breath and extreme fatigue. For the diagnostic evaluation of ACS and myocardial infarction, tests are done to identify the main cause of the disease. These are: Number 1. Characteristic of chest pain and clinical history. Number 2. Blood tests. such as hemoglobin to rule out anemia, which may reduce myocardial oxygen supply, glycated hemoglobin test and fasting lipid panel to rule out modifiable risk factors for coronary artery disease, coagulation studies, C-reactive protein to determine inflammation, homocysteine, elevated levels of homocysteine can cause damage to the artery lining, and lipoprotein, an increased level is associated with a twofold risk in developing coronary artery disease, and cardiac markers, creatine kinase, and its isoenzyme CKMB, and troponin 1 to determine the presence and severity of cardiac insult. Number 3. Resting ECG may show left ventricular hypertrophy, ST, and T wave changes, arrhythmias, and Q waves. Number 4. ECG stress testing. Progressive increases of speed and elevation walking on a treadmill increase the workload of the heart. ST and T wave changes occur if myocardial ischemia is induced. Number 5. Radionuclide imaging. A radioisotope, thallium-201, is injected during exercise as imaged by camera. Low uptake of the isotope by heart muscle indicates regions of ischemia induced by exercise. Images taken during rest show a reversal of ischemia in those regions affected. Number 6. Radionuclide ventriculography or gated blood pool scanning. Red blood cells tagged with a radioisotope are imaged by camera during exercise and at rest. Wall motion abnormalities of the heart can be detected and ejection fraction estimated. Number 7. Cardiac catheterization. Coronary angiography performed during the procedure determines the presence, location, and extent of coronary lesions. Number 8. Positron emission tomography. It is a cardiac perfusion imaging with high resolution to detect very small perfusion differences caused by stenotic arteries. It is not available in all settings. And number 9. Electron beam computed tomography. It detects coronary calcium, which is found in most, but not all, atherosclerotic plaque. It is not routinely used due to its low specificity for identifying significant coronary artery disease. For medical treatment of acute coronary syndrome and myocardial infarction or heart attack, this include oxygen therapy. This treatment increases the amount of oxygen your lungs receive and deliver to your blood. Pharmacologic treatment such as aspirin or other prescription blood thinner drugs to prevent blood clots. Thrombolytics, also known as clot buster drugs to break up existing blood clots. Nitrates such as nitroglycerin and calcium channel blockers such as morphine. To relax coronary arteries and relieve pain of the angina due to muscle spasm. And beta blockers to slow down the heart rate and thereby reduce oxygen requirement. Doctor may also immediately recommend surgical procedures such as coronary angioplasty and coronary artery bypass graft or CABG. In coronary angioplasty, a balloon-tip catheter inflate inside the coronary artery to open it. After inflating, the balloon catheter may leave behind a mesh-like device called as stent to hold artery open or patent. During CABG, a healthy artery or vein from the body is connected, or grafted, to the blocked coronary artery. The grafted artery or vein bypasses, that is, goes around, the blocked portion of the coronary artery. This creates a new passage, and oxygen-rich blood is routed around the blockage to the heart muscle. Other surgical interventions include coronary atherectomy and transmyocardial revascularization. In coronary atherectomy, a blade-tipped catheter is guided into a coronary vessel to the site of the plaque. Depending on the type of blade, the plaque is either cut, shaved, or pulverized, and then removed. Requires a larger catheter introduction sheath, so its use is limited to larger vessels. In transmyocardial revascularization, small channels are formed in the myocardium to encourage new blood flow by means of laser beam. The main common nursing diagnosis of acute coronary syndrome and myocardial infarction include acute pain related to tissue ischemia as evidenced by reports of chest pain, risk for decreased cardiac output, and risk for ineffective tissue perfusion. General nursing interventions for acute coronary syndrome and myocardial infarction include: Number 1. Monitor and document characteristic of pain, noting verbal reports, nonverbal cues, moaning, crying, grimacing, restlessness, diaphoresis, clutching of chest, and BP or heart rate changes. Obtain full description of pain from patient including location, intensity, using scale of 0 to 10, its duration, characteristics such as dull, crushing, described as, like an elephant in my chest, and radiation. Assist patient to quantify pain by comparing it to other experiences. Rationale: pain is a subjective experience and must be described by patient. Provides baseline for comparison to aid in determining effectiveness of therapy, resolution, and progression of problem. Number 2. Review history of previous angina, anginal equivalent, or MI pain. Discuss family history if pertinent. Rationale: delay in reporting pain hinders pain relief and may require increased dosage of medication to achieve relief. In addition, severe pain may induce shock by stimulating the sympathetic nervous system, thereby creating further damage and interfering with diagnostics and relief of pain. Number 3. Instruct patient to report pain immediately. Provide quiet environment, calm activities, and comfort measures. Approach patient calmly and confidently. Rationale: is to decreases external stimuli, which may aggravate anxiety and cardiac strain, limit coping abilities and adjustment to current situation. Number 4. Instruct patient to do relaxation techniques, deep and slow breathing, distraction behaviors, visualization, guided imagery. Assist as needed. Rationale: relaxation techniques is helpful in decreasing perception and response to pain. Provides a sense of having some control over the situation, increase in positive attitude. Number 5. Check vital signs before and after narcotic medication. Rationale: findings such as hypotension and respiratory depression can occur as a result of narcotic administration. These problems may increase myocardial damage in presence of ventricular insufficiency. Number 6. Administer supplemental oxygen by means of nasal cannula or face mask, as indicated. Rationale: it increases amount of oxygen available for myocardial uptake and thereby may relieve discomfort associated with tissue ischemia. And number 7. Administer medications as indicated such as anti-anginals such as nitroglycerin, isosorbide dinitrate, and mononitrate. Nitrates are useful for pain control by coronary vasodilating effects, which increase coronary blood flow and myocardial perfusion. Peripheral vasodilation effects reduce the volume of blood returning to the heart, preload, thereby decreasing myocardial workload and oxygen demand. Beta blockers such as atenolol, pindolol, propranolol, nadolol, metoprolol. Important second-line agents for pain control through effect of blocking sympathetic stimulation, thereby reducing heart rate, systolic BP, and myocardial oxygen demand. May be given alone or with nitrates. Note: beta blockers may be contraindicated if myocardial contractility is severely impaired, because negative inotropic properties can further reduce contractility. And analgesics such as morphine and meperidine. Although intravenous, for morphine is the usual drug of choice, other injectable narcotics may be used in acute phase and/or recurrent chest pain unrelieved by nitroglycerin to reduce severe pain, provide sedation, and decrease myocardial workload. IM injections should be avoided, if possible, because they can alter the CPK diagnostic indicator and are not well absorbed in under-perfused tissue. The prognosis of the client with acute coronary syndrome and myocardial infarction is not good. Chest pain or discomfort can be a sign of serious and life-threatening conditions. Immediate treatment is needed if when signs and symptoms appear. The survival rate depends on the time of intervention given, the availability of health facilities and the capacity of the health facilities to perform immediate surgical intervention. Thank you for listening. I hope you learned something. Again, I'm a fruit of Zeke's imagination, all info given came from him. All credits to you, brother. Ha 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 ha. Back to you, Zeke. Tots 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 tots. Low battery. Shutting down.
Thank you, Rigo. So that would be all, everyone. I hope you learned something. Thanks for watching.